Hello, everyone. We'll get started, Asa. This is Yasser. I'm one of the second-year internal medicine residents, and I will be presenting emergent floor issues. And today it will be about tachyarrhythmias recognition and management. So when you get this page overnight or during the day, whenever you're on call, the nurse is freaking out, the patient's heart rate is 180. So first step is that you don't freak out as well. Just take your time to think and remain calm. And then, so we'll go ahead. So what's tachycardia? Tachycardia is defined as a heart rate of 100 beats per minute. But then, before anything, before you go and look into patient's chart, or before you go and see the patient or anything, you have to make sure three things are addressed, or three things are available by the time you see the patient. You will ask the nurse for full set of vitals. That's the most important thing that will completely change your management. So you need to know what are the patient's vitals. You want the patient to be connected to a telemetry monitor if he's not already connected to one, and you want a stat EKG. And the reason why you get a stat EKG is that you want to get a full 12-lead picture of what's happening, and you want to. Some of these arrhythmias are just transient, so you will not be able, by the time you go see the patient, that you will have a look on everything. So you want to get a stat EKG immediately, and then look at it to be able to find out what's the underlying rhythm. And once you have these, take a look at your patient's chart, have a look on him, and then go see the patient. So before we go ahead, the way I was like, the structure of this emergent floor issues was planned to be is that we'll go like case by case, but the way I thought, like, since tachyarrhythmias is like a very big broad topic, is that we'll just go over it as a scheme or like general approach, and then we'll discuss cases later on. So your $1 million question is, is the patient hemodynamically stable or not? So tachycardia, the patient's heart rate is 180. Your next most important question and most important thing to assess hemodynamic stability for this patient. So you want to make sure, you want to check if the patient is hypotensive or not, if he's having any acute altered mental status or not, having any signs or symptoms of shock, and if he's having any acute new onset ischemic chest pain or chest discomfort. If he's having any of these 4 or 5 signs or symptoms, this will completely change your management. So make sure for every single patient you get called about for any kind of arrhythmia, you don't know about it, you don't know what the arrhythmia is or what's going on with the patient. You just heart rate 150, heart rate 200. Is the patient hemodynamically stable or not? That's the first thing that pops up to your mind, and that's the first thing you go to the room, and your goal is to know, is he hemodynamically stable or not? And before we go further, we always, in every single morning report, in every single patient you see, you read the patient's EKG. And in order to understand if this patient's having a sinus rhythm or not, you need to be able to identify what's sinus rhythm. And sinus rhythm is, you have to have 3 characteristics to be able to define this rhythm as sinus or not. And they are having a P wave before every QRS and having QRS after every P. And you have upright P wave in lead 2 on the telemetry, or if you have a full EKG lead, upright wave or positive wave in leads 2 and 3, and negative in leads AVR. And that's based on the anatomy of the sinus SA node and the way it propagates the impulses down to the ventricles and the way the leads 2 and 3 are placed on the patient's body and the way AVR is on the opposite side. So the way the impulse propagates from the SA node downwards, it goes towards 2 and 3. So no matter what the patient's rhythm, no matter what his current rhythm that he is in, if it is impulse that's from the SA node, it should be positive in leads 2 and 3, and it should be opposite or should be negative in lead AVR. So now you knew that the patient's heart rate is above 100, so he's in tachycardia. Your next two questions are, what's his QRS looking like, and what's his R to R interval? And this will divide this will split your differential into 4 big groups. So the first question is whether is it a narrow or wide complex, and this is based on the QRS duration, which is above or below 120 milliseconds, which is 3 small squares. So this will divide the tachycardia into narrow complex tachycardia and then wide complex tachycardia. And then you ask yourself, is it regular or irregular? And if it is regular, so you have regular narrow complex, irregular narrow complex, then regular wide complex, irregular wide complex tachycardia. So I was thinking of using the board behind me, so I don't know if it will be clear on the chart here. Are you able to hear me from here? Can someone speak, Tyler, or?
Yeah, sir. Hang on. Let me switch the camera. Yeah, I can see pretty well.
Okay, sounds good. So we have tachycardia, so heart rate above 100. You ask yourself the next question, which is the QRS, 120 milliseconds. So you will define as narrow complex or wide complex, and then you will divide into, based on the RR interval, into regular and irregular narrow complex tachycardias, and the same in the wide complex tachycardia. So before we go ahead with the, oh, you're holding it. So before we go ahead with the arrhythmias, the normal conduction system, you have the SA node here, you have the AV node, bundle of His, and then it splits into 2 Purkinje fibers. And the way it happens is that the SA node sends impulses all over the.
How did the camera work?
Really?
Okay, can they see now? It's a beautiful Purkinje fibers and a beautiful heart. Keep
Can
going.
someone confirm?
You shouldn't keep saying yes. I don't know if you actually can see. Whatever you say, you should confirm. Whatever happens.
So what happens is that the SA node fires all over the atria, and then since the cardiac myocytes are able to conduct impulses, so they will conduct. But the AV, what you call the separation between the AV, the atria and ventricles is non-conductive tissue. The valves and the fibrous tissue are non-conductive, and the only way it passes is through the AV nodal system. So the only one impulse that comes from the SA node to the AV node is the one that will be conducted downwards. And it will be reflected as a P wave, which is the SA nodal impulse, and the PR interval, which is the AV conduction delay, and we'll use it in a minute. So, and then you'll have the QRS. So this is the normal sinus. Okay, so this is the normal conduction system. What happens in arrhythmias is that if you have an ectopic atrial focus, so you will have an accessory focus that sends impulses in a faster rate than the SA node. So you have ectopic atrial tachycardia. So this is the first one, ectopic atrial tachycardia. So you'll have an irregular rhythm that passes through the AV node with an abnormal looking P wave, but it's consistent in all the QRSs. So every QRS is preceded by an abnormally looking P wave. And however, it's a narrow complex because it goes through the AV bundle. And then of course the sinus tachy. And if the ectopic focus is within the AV bundle, so it's junctional rhythm. So these three, if you have it here, or if you have it here, so these 1, 2, 3, the sinus, ectopic, and junctional rhythms, so they are continuously sending impulses downwards to the ventricle. So what happens if I give adenosine, which is, for example, an very strong, very potent AV blocking agent, but it's short acting, so it will delay the impulses, but it will never stop it because the focuses up there are still going on. And then another regular narrow complex tachycardia is the atrial flutter. So if you have an atrial flutter, the atrial flutter focus in the atria that's continuously sending, but it have a fixed block. A fixed block is that for each like 3 flutter waves you conduct 1, or for each you conduct 2, or for each 4 you conduct 1. So 4 to 1, 3 to 1, 2 to 1. So although it's an atrial flutter, but it's a fixed block, so you will have a narrow complex tachycardia. And then AVRT and AVNRT. And these two I didn't know before I started residency. And I think the first time I heard about them when I was working on call with Abdullah one time, and we started speaking about them. So what is AVRT and what is AVNRT? So we spoke about how the normal conduction system works. So we'll talk about, before we talk about EVRT, we talk about the accessory pathways. So what's accessory pathways? It's something like the Wolff-Parkinson-White syndrome. So in in WBW, you have an accessory pathway here that bypasses as well the AV nodes. Like the AV node bypasses the atrioventricular septum, the accessory pathway bypasses the atrioventricular conduction block that's happening here. So when the SA node fires everywhere, the impulse will be conducted through the AV node, and also one impulse will be conducted through the accessory pathway. But what happens is that the AV node have a delay, but the accessory pathway doesn't have it. So you will conduct the P wave from the SA node. And then by the time this is the AV nodal delay, but the accessory pathway doesn't have it. So you will have a very short PR or no PR interval, and then you will have initiation of a ventricular response. And by the time you reach here, already the AV node have conducted and they meet at here. So you start having the rest of the QRS pathway. So in an accessory pathway, you will have a short PR and you will have a delta wave, which both represent the fast conduction through the accessory pathway. What happens in the AVRT? AVRT is ventricular reentrant tachycardia. So what happens is that the patient is already having an accessory pathway. So in order to have EVRT, you need to have normal and accessory pathways. So you need to have two pathways. And what happens is that you are conducting both of them at the same time, and you are having this underlying rhythm. But what happens is that when there is a premature impulse, single premature impulse, so the SA node fires every, let's say, 1 second. So if you have a premature impulse by the 50% of this, the 1 second, although the AV node have delay, but it have very short refractory period. The accessory pathway have no delay, but have longer refractory period. So by the time this single premature impulse fires, it will reach the AV, it will also propagate all over the SA node, all over the atria, but the only two ways that you can pass through are those two bypasses. So it will fire an impulse to the AV node, and since it's already having a short refractory period, this impulse will be conducted. And once it arrives to the accessory pathway, it's still in its long refractory period, so the impulse will not be conducted, so it will be blocked here. So what happens is that the AV nodal impulse that passed, it will already come upwards, and then since this is conductive tissue, it will cross to the other side. And when it crosses, the only tissue that can accept the impulse or can conduct or can transmit the conduction or transmit the impulse is the AV node. So it will continue. It will reach an impulse here to the AV node, and then it will continuously go in this way. So this is the AVRT and it's called orthodromic. There are two types, orthodromic and antidromic. The orthodromic is when it's going in this way, so it goes through the AV node first and then circles again and again. So it all resulted from a single impulse. And why this is important, why I just took some time to speak about it, is that if I gave adenosine will just restart the circuit. So it's a single impulse. All this AVRT, all this 200 heart rate that's going on is just a resultant from a single impulse. So if I do a vagal maneuver or AVRT, or adenosine, it will just cut this circle, and then this AVRT will completely stop. What happens in AV-NRT is something similar. I will not go deep into it, but it happens within the atrioventricular nodal tachycardia. So it happens within the this is the AV node. So it happens within the AV node, and the circle goes within the AV node itself. So if I give adenosine, if I give a vagal maneuver, or if I put my finger here and restart the circuit, this tachycardia will end immediately. So AVRT or AV-NRT, if I give them any AV blocking agent or AV blocking maneuver or whatever, I restarted the circuit, so I will stop this arrhythmia. In comparison with the other arrhythmias that I will just delay it, but the focuses are still up there firing, so it will not stop. So this is regular narrow complex tachycardia. I just used the board to explain the AVRT and AV-NRT. I think I'll sit back and continue with the rest. Thank you, Majid. Sorry, guys, for this long talk. So regular SVT, you have sinus tachy, you have AVRT, AV-NRT, and AVRT, atrial flutter with a fixed block and ectopic junctional rhythms. And then for irregular SVT, the most common arrhythmia, the most the most common thing that you will face, or the most common thing that you will see, is AFib with RVR. So AFib with RVR is the most common rhythm overall and most common irregular SVT that you will see. Atrial flutter, as we discussed, it can present in fixed or variable blocks. So if it came in a variable block, you conduct 3-to-1 and then 2-to-1 and 3-to-1 and 2-to-1. So it will appear as an arrhythmia, it will appear as an irregular R2R, and it will be an irregular narrow complex tachycardia. And then the last thing is multifocal atrial tachycardia, when you have not only single ectopic focus, as here, so you have a single ectopic or single abnormal P wave, but you have multifocal atrial tachycardia, so you have at least 3 abnormal P waves. And since you have 3 abnormal foci that are firing, you will have an irregular heart rate with at least 3 abnormal P wave morphologies within the same rhythm and within the same, lead strip. So your first question after hemodynamic stability, wide or narrow, and based on that, you decided this is narrow complex, and R2R, you decided this is irregular or irregular. The same, so you ask yourself about the QRS, it's wide, so it's above 3 small boxes, or it's above 120 milliseconds, so this is wide complex tachycardia. And you always hope that you don't see irregular wide complex tachycardia, because they are the malignant ones. They are the ones that you will likely see when there is a patient coding or he's in cardiac arrest. So irregular wide complex tachycardias are the VFib, the torsades, or the polymorphic VT. However, the regular wide complex tachycardia. So this is a very, very big topic that often gets very confusing, which is monomorphic VT. So why it is actually, so before we go through it, why it's actually wide complex, because it's a ventricular impulse. So it doesn't go through the AV node, so you don't have the regular narrow complex that you know. So it's an impulse that's resulting, or that's firing from within the ventricle itself. So you have a wide complex. However, if you have a right bundle branch or you have a left bundle branch, I don't know if you heard Abdullah, but what we're saying is that when it goes through the Purkinje fibers, that's why it's a fast conduction, and that's why you have the narrow complex. But what happens in the ventricular tachycardias, or in any tachycardia with a wide complex, is that it fires through the ventricle muscle itself, and then it's slower than the Purkinje fibers. So that's why you have the QRS wide and above 120 milliseconds. That's we are mentioning. So you can have, so basically it can be from the ventricles, but what happens if you have an underlying block that, so what happens in blocks, before we talk about it, so if you have a right bundle branch or a left bundle branch, what happens is that you send the impulse from the SA node down the AV node, and they conduct down the Purkinje fibers at the same time, left and right. But if you have a block in the right side, the left will conduct, so the initiation of the QRS will be at point, that's a small square number 1, and then by the time it ends, there is a right bundle branch, so there is a delay. So by the time the delay ends, you have a result of a long or a wide complex, or a wide complex. So regularly in a patient with just a sinus rhythm, he can still have a wide complex because of an underlying bundle branch block. So, and the reason is that, as we mentioned, there is a delay in one of the Purkinje fibers, right or left, or one of the fasciculae. So if this block of this right bundle branch block in a sinus rhythm transitioned or converted into one of these, for example, regular SVTs. So you have a regular SVT, but with an underlying right bundle branch. So it will appear as this one. So it will appear as a tachycardia with a wide complex, but it's not ventricular tachycardia. It's a supraventricular tachycardia, or it's a, sinus tachycardia, or it's an AVRT, but with an underlying aberrancy or underlying something that caused the QRS to be white. And the big question.
A wide complex that's irregular can be named if the patient has a baseline level of branch. You can answer that later on.
Okay. So the big question is, okay, I have a wide complex regular tachycardia, how to differentiate if this is ventricular tachycardia or if it is just a supraventricular that's having an underlying aberrancy, and this will change your management, basically. Before we go further, the most common is VTs, and the worst is VTs. So if you are in doubt, if you are unable to decide, if you are in a situation that you have to make a decision right now and I'm unable to decide this is an SVT with aberrancy or this is an underlying VT, treat it as a VT. So there are a lot of criteria. There is a lot of criteria people came up with to define the VTs versus SVTs, but the main criteria that we follow is the Brugada criteria. And the Brugada criteria is mainly, so it's here in this upper box. So first thing is that if it is ventricular, all the impulses will be from a single focus in the ventricles. So all of the waves will be looking, all of the precordial waves, V1 to V6, will be looking towards the same, will have the same wave. So you will have something called positive concordance or negative concordance, which is all the QRS complexes are positive or all the QRS complexes are negative and leads V1 to V6. So this one, if you have positive or negative concordance, that's a VT. If not, you go to the next question, which is the duration of R to S. So onset of R to the nadir of S, which is the lowest point of the S wave. And if it is above 100 milliseconds, it's a VT. If not, you will go to the next question, which is AV dissociation. And for AV dissociation, as we just mentioned, if it is an SVT with aberrancy, you have an P wave that's resultant from an S anodal impulse or sinus rhythm. So in order for this wide QRS to be there, you need to have a conducted P wave. So in order to, if it is an SVT, you will have a P wave that's preceding every single QRS. However, if it is VTAC, it will be completely regardless. So you have a sinus node that's firing, and you have a wide complex QRS that's resultant from the ventricles that's completely regardless to the P waves. So if you have AV dissociation, that's a clear cut that this is VTAC. So, and before I go further with the rest of the Brugada criteria, Brugada criteria are 4 questions, and there are 2 extra things. So as we just mentioned, the AV dissociation and the impulses coming from the atria downwards to the ventricles. So if it is a ventricular tachycardia, there is continuous firing from the ventricles. But if there is a spot that one of the SA nodal impulses that are coming from the SA node gets just conducted to the AV node, this will result in a normal QRS. So this is called captured beat. So if you have a captured beat, which is a normal looking QRS, just, so this is a conducted beat that came from that find its way, that sneaked in within the continuous wide complex tachycardia within the ventricles, and it's find its way to be conducted. So if you have a captured beat, if you have a single regular narrow complex, this is a VTAC. And then there is something called fusion beats when there is the same. You have a captured beat, but it didn't complete its full QRS, so it captured, so it got fused with another one of the VTACs. So if you have a captured beat, if you have a fusion beats, these are defining also for VTAC. And then morphology criteria. So Morphologic criteria is a very, very big topic. I will not go through, but just generally talking, this is the standard looking right bundle branch block. You have initiation of the R, then since there's a delay, and then you have the rest of the R following through. So this happens because of the delay that's in the right bundle branch. So usually you have a taller second R. So the second R is always taller if this is a standard right bundle branch block in any normal person in any sinus rhythm. However, if it is a VTAC, it will be split, but it will be, the first R is longer. So these all are morphology criteria. These are all things that you will look into the QRS to decide if this is VTAC or SVT. I'll not go through for time's sake, and but just remember, at least you know now at least 5 criteria. You know positive and negative concordance on all precordial leads, which are V1 to V6. You know R to S above 100 milliseconds in any of the precordial leads, which is V1 to V6. You know AV dissociation, you know fusion beats, and you know capture beats. So quickly, this is positive concordance. So all of the V1 to V6 are all looking upright. All are positive. And this is negative concordance. All the QRS leads are looking downwards. Sorry, all the precordial of V1 to V6 are looking downwards. And this is, you have V1, V2, V3 are positive. And then as of V4, 5, and 6, they are more downwards. So the QRS is looking downwards. So look at V1 and look at V6. Yes. So this is SVT, because this is not a consistent positive concordance in all of them and not a consistent negative concordance in all of the leads. So this is SVT. And this is the RS interval and the AV dissociation. So look at the QRSs. They are just firing. They are just going on. And then look at this P wave here. P wave at a different spot here. P wave at a different spot here. At a different spot. So this is AV dissociation. Every P wave is just going on, regardless of the QRS. Where are they? And the same here. Look at the P wave. So this is a P wave here, another one here, another one here, another one here. So it's all over the place. So this is AV dissociation. And the black arrow here, if anyone can recognize this, any of the residents here. So this is capture beat. So you have a regular wide complex tachycardia, and then you find a single narrow complex QRS that looks similar to patient's baseline. So these are always coming from the ventricles, but this one find its way and sneaked from within these complexes from the SA node. So this tells you that this is ventricular tachycardia. And the morphology criteria, I'll not go through it. So you looked at the rhythm, you had a big picture, at least you divided your patient into 4 categories, and you were able at least to put your patient or categorize your patient under narrow complex regular or narrow complex irregular. But always remember your first question, whether the patient was hemodynamically stable or not. So if the patient is hemodynamically stable, if he was hypertensive in the morning, and then by the time he had the tachycardia, his blood pressure is 70/30. So this patient is hemodynamically stable. So your next step will be cardioversion. You will shock this patient. And why I have this picture back in the ground here, because the first time I had to shock someone, I didn't know how to open the door of this machine. So this is the defibrillator, by the way. So you have like something like a door here, something like that covers it. You open it, so you turn on the machine. If the patient is having any arrhythmia other than wide irregular, other than VFib or torsades, you will deliver a synchronized shock. So once you open the defibrillator, the first thing is to synchronize the shock. So you will synchronize it, then you will choose the energy, then you will charge it, and then you will deliver the shock. And the way I remember it is 100 to 100, 100. 100 regular narrow complex, 200 irregular narrow complex, 100 regular wide complex. So narrow complex, regular narrow complex tachycardia, by the book you deliver 50 to 100. Usually we deliver 100, and then narrow irregular like AFib or like atrial flutter with variable block, patient is unstable, you will deliver 120 to 200. And wide regular, the patient is having monomorphic VT or SVT with aberrancy, which you are unable to decide, you will deliver 100 joules if the patient is hemodynamically unstable. And one thing to mention is that don't be afraid of shocking someone. The harm of shocking someone is just pain. But the benefit is that you could save this patient from going into cardiac arrest or death. So the patient who's already hemodynamically unstable from an arrhythmia, he's heading his way or her way towards cardiac arrest. So the way you will save this patient, or the way you will revert his rhythm, and you will see how surprisingly you will have these positive outcomes from shocking someone. Of course, discuss it with your senior, of course, discuss it with your attending if he's available, but don't be afraid of shocking someone. If it is wide irregular, you will do an unsynchronized shock. So generally talking, you have a narrow complex tachycardia. So you know that this tachycardia is resultant from anywhere above the atrial, above the AV node. So you will try to do anything that will suppress passage of these impulses from the atria downwards to the ventricles. So you will start with the vagal maneuvers, which will affect the AV node. So we'll talk about the vagal maneuvers in a second. So if vagal maneuvers doesn't work, and all of these are if the patient is hemodynamically stable. Vagal maneuvers doesn't work, you will try adenosine. And also adenosine, don't be afraid of adenosine. The half-life of adenosine is 0.6 seconds to 10 seconds. So the effect will be done by almost like 40 to 50 seconds. The adenosine will not be longer affecting the patient. So you will, and it's a very, very potent AV blocking agent. And the thing, why would you use adenosine is that, as we mentioned in the AVRT or if AVNRT, if the patient's having supraventricular tachycardia, any of these either two, this will just completely abort it. And then if this doesn't work, you will go to your AV blocking agents, calcium channel blockers, or beta blockers. On the other hand, wide complex tachycardia, you will try vagal maneuvers. If the patient is stable, you will give yourself a chance with it. In case this is an SVT with an underlying aberrancy. Adenosine use in wide complex tachycardia is questionable. However, ESC guidelines say that you can use it in regular wide complex tachycardia in case it's also an SVT that, like an AVRT that's with an underlying bundle branch block that can be aborted. However, you tried vagal maneuvers, they didn't work. Your next step is anti-arrhythmics. And guidelines says procainamide and then amiodarone. I never got chance to amiodarone. I don't know if any of the seniors here have ever used procainamide, but I never used it. And we always go ahead with amiodarone. And if the arrhythmia doesn't, if a wide complex arrhythmia doesn't revert with, or doesn't convert or switch back, or continues even after starting the anti-arrhythmic, you can give a therapeutic synchronized cardioversion even if the patient is hemodynamically stable to bring him back to control the tachycardia. So quickly, vagal maneuvers are Valsalva and carotid sinus, and these two you will never use them, so forget about them. So adenosine, you give a first dose of 6 milligrams IV push. If you don't see effect, give another 12 milligrams IV push. And guidelines says you can give the third dose as an 18 milligrams. I never got to use it, and I don't know if anyone used it before, but You always talk to the patient about the side effects. So adenosine will cause significant facial flushing. It can cause shortness of breathing and dyspnea. So talk to your patient about it before you give it. And it will cause a sinus pose because it's a potent AV blocking agent. So it will block completely the AV node. So talk to your patient about it. And the effects you will see from the adenosine. If there is no effect in a narrow complex tachycardia, this is nonsense because your narrow complex is from the atria. So you should, no matter what, have a delay in the rhythm or stop the rhythm if you gave adenosine. So maybe it was not an effective dose. Maybe it went under his skin. Maybe something happened. So if you gave the 6 milligrams, you don't see anything, give the 12 milligrams. The other thing is that high septal ventricular tachycardia. So the ventricular tachycardia is resulting from very high in the septum, just above the AV node. It will result in, you will not have the effect of the adenosine, but no effect of adenosine, you go ahead and give the next dose. And then you have two effects. One is sudden termination if the patient is having AVRT or AVNRT because it's a circuit and you restarted the circuit. But if it is sinus tachy or junctional or ectopic tachycardia, you will transiently slow it down. You will be able to look at the tachycardia closer and you'll be able to assess the P wave closer, but it will go back again and reaccelerate again. And calcium blocking agents, you have the cardism. In the hospital here in the EPIC, it's an order set, cardism bolus, then a drip, the beta blockers, ismolol and metoprolol. So you will use this cardism bolus and drip. It comes in both. You'll use 5, 10, 15, or 20 as a bolus, and then you start the drip and the infusion drip. It's just an order set. You will fill everything. And the ismolol, the same, it's a drip. You will just mention the heart rate that you want. And the metoprolol, it's a 2.5 milligrams. You give them with a max every 5 minutes with a maximum of 15 milligrams. Anti-arrhythmics, procainamide, 20 to 50 milligrams per minute. I never used it. And then amio. Amio is 150 milligrams bolus. You give it over 10 minutes. And then you start a drip. And if the patient is still in arrhythmia, you can repeat the 150 milligram bolus. And it also comes in a order set in EPIC. So quickly, before we run out of time, so Khalid, do you mind doing this one, please? I'll show the EKG in a minute, in a second. So one heart rate above 100, so this is tachycardia. Narrow complex. Regular RR interval. So at this point, yes, it's not sinus, but the heart rate is very, very high. It's almost 220 or above. So maybe you have a P wave that's masked under the QRS. So what is sufficient for you to know is hemodynamically stable or not, narrow complex, regular, like you define it under which category of those. So based on this, you go to the patient's room, what will you do? Exactly, so you will try vagal then adenosine. If it doesn't stop the SVT, it will slow it down and you will be able to look what this rhythm is looking like, and then you can start beta blocking agent or calcium, AV blocking agent after that. So you will go with C. Amira, can you do this quickly? Pressure. Yes. No. Yeah. This is atrial fibrillation, but generally you quickly ran into the patient's room. What you need to know is is the patient hemodynamically stable or not, and irregular narrow complex tachycardia. So what will you do next? Yes. Yes. All of these are true cases. And this patient, for example, was at least 7-8 hours till the next morning. He was already, by the time we went, he was already maxed on 2 pressors. Just a single shock will completely bring him back. So yeah, send pan cultures, do everything. Why he went into AFib and maybe he's septic or whatever. You will start an anti-arrhythmic, but what you need to do right now, he's hemodynamically unstable. Shock him. So it will you will be surprised how this patient blood pressure will go back to normal just with a single shock and just with bringing his heart rate into sinus back again. So this guy is irregular narrow complex tachycardia. You will shock him with how much joules? Yeah, so 100, 200, 100. So you can do 120 up to 200, or you can just go ahead and do the 200. And then please shock this patient. And then the most common page you will get as a junior. The patient had 15 beats of VTAC. What will I do? Okay. So why I brought this is that non-sustained VTAC. This is non-sustained VTAC. So it's very common. It often happens to patients while they are sleeping, completely asymptomatic. It might be happening while he's at home. More than 3 beats of white complex, that terminates with 30 seconds. So 30 seconds will be probably like 90, 100 beats, something like that, but you can measure it. So it's non-sustained VTAC. First question you ask the nurse, was he symptomatic or not? Was he having any kind of symptoms? Did he feel it or not? And then how frequent it is it recurrent? How often does he get these? If they are recurrent, if they are frequent, they could be symptoms of an underlying cardiovascular abnormality or underlying structural heart disease. But if it's just a single asymptomatic, you can just get electrolytes, full EKG, which will likely not show anything by the time because it's already aborted by itself. But if it is recurrent, frequent, symptomatic, you can work up the patient for an underlying structural heart disease. And sorry for this long lecture, but any questions?
Yeah, sir, not a question, but a comment. Most of the time, other than the 6 to 5 to whatever beat run of VTAC, you'll get called by the nurses, especially in the ICU, and they're going to say the patient's in SVT. Always they say SVT. And what you have to think about is the common rates for SVT, like 180 to 220, whereas AFib, you're going to be looking at above 100 to 180. And if the patient is stable or at least a little stable, you need to wait for the EKG before you treat it, whatever it is, because AMEO is going to work much more effectively on AFib than trying to give them vagal maneuvers and adenosine.
Yep. Thank you, Tyler. Any questions, anything else? All right, sounds good.